Welcome everyone. My name is Anshul. I'm your host, and I today have again with me Soham. And today we will be talking about India's pharmaceutical future. Particularly, we'll be talking about what are the challenges with India's pharmaceutical industry, the healthcare spends, and Soham would be introducing us to some of the policy ideas that he's been brainstorming on, and he's also worked on a report on that. So I'm really excited for today's episode. And what we'll do is, since the ideas are deep and we want to build an intuition for the audience to really understand them, so probably we will be doing multiple episodes on this idea of pharmaceutical Gordian knot, breaking the pharmaceutical Gordian knot. That's what Soham has called it. So let's begin. We'll probably have maybe more than one episodes. We'll start with the first part of it today. All right, Soham. So let's get started. What game-changing ideas are we going to discuss? But before that, let's start with the problem statement. What is it that we are trying to solve here today?
Yeah. So the policy paper is called actually the Breaking the Gordian Knot, solving the Indian pharmaceutical industry's trilemma. Now, you can basically, there is a threefold problem that are counteracting with each other. And that basically is the cause of the trilemma. So what are the three causes, three problems really? So first is the affordability problem. India lives in many centuries at once, and also India lives in many continents at once. There are sections of India which has the lifestyle of US, and there are sections of Indian population which has the lifestyle of sub-Saharan Africa. So the point is that for any government, balancing the affordability mandate is one of the key social welfare challenges that it faces. But the idea for affordability is not necessarily only limited to the social welfare angle. As I'll try to talk to you through the rest of the episode, there is a conservative liberal approach to thinking about this problem as well. But apart from that, if government tries to build policy solutions to mandate affordability, that drugs should be affordable, it directly impacts on the quality and the innovation aspect of it, specifically innovation aspect of it. So what would really be the motive and incentive for a private company to innovate when it knows that it cannot eke out the profits that it wants? And herein is basically the counteracting forces of the need for affordability and the need for innovation. And let's not get it wrong. India has many, many pharmaceutical and healthcare problems that no one else is going to solve for us, specifically tropical diseases. How do we really, US or Europe for that matter, where the bulk of the innovation is happening, they do not need to bother about how to solve dengue and chikungunya, but we need to. Yeah. So there is a problem of innovation, which basically comes head to head and face to face with the affordability mandate. And sitting ensconced between these two problems is a quality problem, because quality is both a manufacturing problem, and thus people may be cutting. So one way to think about it is this thing that the entrepreneurs may be cutting corners because there is an pressure, a cost pressure to make the drugs affordable and low cost. So they will be kind of cutting across the quality control parts. And even if there was none, even if there was no cost pressure, still maintaining the quality controls, quality standards is directly in the remit of state action. And that, speaking from completely conservative liberal, classical liberal kind of a mindset. So in this entire ecosystem, also is the problem of alternative medicines, also is the problem of overtreatment, also is the problem of how do you kind of take care of other healthcare problems like antimicrobial resistance and all those things. So not all of them are pure play pharmaceutical problems. They sit in the boundary of pharmaceutical and clinical practices. But there will be repercussions of what we do in pharmaceutical onto these interface subjects and interface problems. So this is the trilemma, that how do we really solve the affordability problem while ensuring that the innovation really happens in India and global South related healthcare problems, all the while ensuring that the quality controls are taken care of or adequately taken care of.
So
So this is basically the trilemma. Yeah,
the three things which I understood was the trilemma you're talking about. One is cost, second is quality, and third is the innovation problem.
that's right.
Right.
That's right.
Um, could you also, in your introduction to the problem, could you also run us through some numbers which actually tells us how bad it is? For
Yeah,
example, I
yeah.
was reading through your document and you mentioned there's an out-of-pocket expense of 51%. So what does that mean? I mean, if you could
Yeah.
understand
So
some
just to fix, some intuition around the problem, the extent of the problem, and the numbers differ from year to year and researcher to researcher, because it is very difficult to have a very precise number. But as late as just early as 2017-18, the number of out-of-pocket expenditure was 51%. That means of the 100 rupees that basically a person spends on his healthcare, the 51 rupees was out of his own pocket, and the rest 49 rupees was either subsidized by the state or subsidized by or paid by the insurance or what the rest of the works. So now the point is this thing, that this 51% number is also broadly very much dominated by the cost of drugs. And hence, if you solve the problem of affordable drugs, you actually are able to kind of bring the entire affordability problem or out-of-pocket expenditure problem from 51% to at par with the developed countries, which actually have out-of-pocket expenditure number of somewhere roughly about 2 to 3%. And we do not, and it's fair to consider, fair to temper our ambitions. We are still a poor country. We do run into the state capacity problems. So it does make a lot of sense for us to temper our ambitions. So even if we get to a 12 to 13 to 14, 15% ratio, that is a huge amount of wasteful expenditure that we can basically divert to more productive use cases. And that is the direct effect of what would we achieve if we basically are able to redirect these resources. And just to further add the numbers, roughly, India spent about $100 billion in healthcare, and that includes private as well as public. So, and roughly it is basically 50-50 ratio. So the point is, if $51 billion of this entire expenditure is spent and borne by the individuals, and if we are able to reduce it to $15 billion without considering the growth in GDP, because as India grows, so will the GDP will grow, and so will the kitty will grow. So the savings will be even further, even higher than what I am kind of talking about here. But even if we consider that GDP growth is zero and all these savings happen today, so from $51 billion of spending to $15 billion of spending, that basically this entire corpus, which is roughly about $36 billion, that kind of, drives, has the potential to drive a lot of stuff. So That's the basically the long and short of the cost problem that we are looking at.
So before we double click on cost problem, maybe if you could help me understand how these three trilemmas, of course, we'll go into them one by one. We'll start with the cost and affordability issue. But why do you think these three are closely coupled or intertwined? Why is it, why it is not a good idea to look at them in isolation?
Yeah, yeah. See, the problem is that India's affordability problem. Let's take that for the example. India's affordability problem also includes a tacit assumption. The problem is not that we are looking for the affordability of low quality drugs. We are looking for affordability of drugs that are of high quality, that are effective, that are clinically, pharmaceutically proven to have that proper intervention. If I am a Hakim or if I am an alternative medicine practitioner and I actually, cook up some concoction and give it to you, and I charge 10 paise for that, yes, it is quote unquote affordable, but is it a drugs really? Or is it a pharmaceutical invention per se? So the essence that I'm trying to drive at is that quality is a cost, but you do have the pressure to reduce the cost. How do you ensure that the cost reduction happens via process innovation, via via process innovation, via clinical innovation, via pharmaceutical innovation, and not through cutting corners at the very thing that you really want to ensure is at the highest level, quality. Yeah. And now to drive down, so ensure that the cost cutting or that economical drugs is happening because the manufacturing improves, the manufacturing processes improves, the business processes improves. This improvement is directly linked to innovation. And innovation is not for free. Yeah. So innovation costs money as well. So the problem is that for a private person to ensure that his drugs or his products for that matter, and it doesn't require to be pharmaceutical products. If you are making a mobile phone, if you have to if you have to compete on cost without compromising on quality, you have to invest in innovation. However, the problem is, where will the money for quality and innovation come when your profit is crimped? And that is where basically the entire conundrum for a private entrepreneur is, that how do I really balance these three counteracting forces? And that is basically the effect and the cross effect between that. If I try to reduce cost, it is very much possible that I'll be doing it by crimping back on the quality quotient or the innovation quotient. And so we are getting stuck into a low equilibrium, a low quality, local minima for that matter. Yeah.
Great, great. Yeah. So let's double click on
Yeah,
affordability.
sure. So what exactly is the affordability problem for that matter? So we discussed briefly about the numbers, but the idea is that you really have to kind of open up the innards of the problem to understand where exactly is the burden of expenses coming from. Yeah. So the first thing to understand is this thing that, do we not have insurances? How do the developed economies solve it? And what is the problem that we face in the Indian context? So a good idea to think about is this way, that what are pharmaceutical products for that matter? So pharmaceutical products basically are rival and excludable goods. As Economics 101 says, that basically any good that is a rival good, implying if I buy a unit of that product, the other person is not able to buy that product, that by that unit per se, that is basically the rivalrous nature of product, of a good. And if someone is able to set up a barrier to access to that product, that implies the excludability aspect of it. Pharmaceutical goods, much like mobile phone or laptop or any other thing that we are used to, are also rival and excludable goods. However, there's a catch. The catch is, unlike discretionary products, they are time critical. So if I need my drugs now, I need them now. And to a huge extent, they are not substitutable. What really happens in normal economics is, if the cost of tea goes up, I'm going to kind of switch to, say, for example, coffee. And if the cost of bread goes up, I'm going to switch to roti. So problem is that pharmaceutical interventions are not substitutable easily. They are not postponable, if I can use a colloquial word. They are time critical. And of course, they have inelastic demand curve. If I need a product, or if I need a pharmaceutical drugs in this dosage and this quantity, I need that. I cannot basically regulate my dosage or my frequency of drugs. So this poses a unique conundrum. Pharmaceutical interventions may be rival and excludable goods, but they are not really behaving as any other goods per se. And this basically translates into that when consumer faces a non-affordable drug, he is not going to delay the transaction. He is going to drive himself to bankruptcy if needed to improve his health. About 11.2 million households were pushed below poverty level due to this expenditure, this high out-of-pocket expenditure in 2012. Some other researchers reveal that outpatient cancer treatments pushed 3 times more households below poverty line than just hospitalizations. So what I'm trying to get to is this thing that in this problem, the poor face the greatest tax or greatest problem because the drugs are not affordable. There's still further evidence that when in a community, in a rural community, or even in a urban, even in a community which is not financially that well off, when there is a health stress and that person in a household, and that person defaults, drives himself to bankruptcy because to fund his health expenses. And when he goes bankrupt, his cost of loans, the loans that he took, the microfinance loans that he took, he's not able to kind of pay back because he has driven himself to bankruptcy because of those out-of-pocket expenditures. The problem is, because that household has defaulted, the cost of loans for that entire community increases. So even if another person who didn't have this much health problem, or who may be creditworthy, the effect of another person in that community, the action of another person in that community is having a negative consequence on him. So what really translates is that the risk of financial ruin has negative externality, especially on communities that are vulnerable. Now, the point that I'm trying to come to is this thing that whenever there is either of the four, market power, so when you have public goods problem, when you have externalities problem, and other aspects, when you have information asymmetry, all these things mandate the government, give the remit to the government to do something about it, to solve the problem. Yeah. So the point that I'm trying to come to is, this is a clear case of externality. And it's even worse because it's externality only in the poorest sections of the society and not the richer sections of the society. So this basically brings us to the problem that how do we really solve the problem of this market access to affordable drugs? So we do find that even though the developed economies love the idea of insurances, and so do we, and so do most of the low developing income economies, there is a problem in terms of how the insurances are designed. For example, all the insurances that we have in India are focusing on hospitalizations. We just do not get hospitalized that often enough that that insurance clause is going to help us avoid our financial ruin. However, we do come across and we do take care of OPD services, outpatient day services, every now and then. Further, when you get hospitalized, if you are under the state insurance remit, your medicine costs are often borne by the hospital and by the state itself. So that is not really causing the 51% OOP problem, and OOP being OOPE, out-of-pocket expenditure. When I am actually using the OPD care day in and day out, and I am basically taking the prescription to the local pharmacy, both that pharmacy can be inside the state health government hospitals or outside. I am basically, paying some money out of my own pocket. If that money was, if I am actually going to the pharmacy inside the state health hospitals, that's better, that's fair, because those hospitals, those pharmacies price the medicines in a subsidized manner, and that kind of brings down my burden on my pocket. But as we will see, that is not really the case often. So I am always forced to go to the private pharmacies. So the idea is this thing that OPD care is basically a bigger problem, and state is not really tackling that. So the lowest hanging fruit over here is, let us expand the current hospitalization insurances to add that OPD add-on.
Is that
Pardon?
Is that how the insurance works in developed economies? They have the OPD covered in the insurance?
Yes, they have. But the point is, so because it is cashless, so that is also included. But the point is, we need not really go for a complete check, a complete mimicry of what is there, what is happening in developed economies. Yeah. So you do have insurances which are covering for your OPD chemotherapy or OPD liver dialysis sessions. So all those things are covered. So in India, it is not. But the overall idea is that insurances are, at least in the private markets, are offering this add-on. Often and it's a bit opaque what is the pricing of this, but it really differs from 630 rupees per person per year in a household to somewhere close to about 1,400 rupees, 1,500 rupees per person per household. So what it really means is, for a family of four, it comes to about somewhere close to about 2,400 rupees to 6,000 rupees. And again, it depends upon the other riders on it. For example, how many OPD visits I am going to allow you and things like that. So the point that I'm trying to get to is this thing that our existing hospitalization insurances need to expand to add that add-on. That's the first thing. The second thing is this, that insurance, and this is where we, as a LDIC country, we kind of make a mistake, that insurance has failed to take off in India, even though we have so many insurance, state-led insurance plans is because we fail to understand two very important things. And insurance is a very complex product. It's difficult to understand its numerous riders, clauses, and these kind of the clauses that are there inside, which is going to honor the claims. That's one thing. The second thing is that even notwithstanding the nitty-gritty details of the insurance, what basically the clauses in the insurance agreement is, when a person actually goes into a state-sponsored hospital, and tries to claim that insurance, it itself is a very cumbersome process. So it's both the lack of knowledge that holds our most vulnerable members of the society back to exploit those clauses, and also to when they know about the insurance product themselves, and when they go to the hospitals, there is a cost, there's kind of a tax on their ability to utilize it properly. I think there's only 9 minutes, 33 seconds. Should we continue?
Yeah, we can continue. 10 minutes is quite.
Okay. Okay.
Once
okay. Just okay. All right. So, there is research that basically, and some ethnographers and anthropologists have found out that there is a much more nuanced understanding and assessment algorithm that an individual uses to understand how good an insurance product is for me. Of course, the usual clauses, like, for example, what kind of protection it offers me, that is the quantitative aspect of it. That is one of the things. The second thing is that what is how many hospitals it helps me to go to. Is it only pushing me towards the state-led hospitals, or is it also allowing me the private hospitals? Further, how complex or easy it is. Further, what is the bureaucratic processes involved in it? And the last thing, and most important thing, and it's perhaps a very non-intuitive thing. Every insurance, and especially which is a state-sponsored insurance, differentiates the holder of that insurance card from another individual whose insurance is not state-sponsored but market-led, but market-bought, market-purchased. When there is this difference, it automatically creates an invisible hierarchy in the minds of the service providers in the hospitals, and which basically directly reflects back into the holders and the users of those state-sponsored insurance themselves. And thus, the people who are holding those insurance cards experience a loss of dignity. So a bureau, yes.
Ayushman Bharat is one of such schemes, right?
Yeah, so it is not necessarily about only Ayushman Bharat only. It's also about, Rajasthan has a Bima insurance. Yeah, so all those insurances are going to kind of, so, and we did have, many such insurances in the past. Yeah, but the problem is this thing that a bureaucrat comes to a colony, straight away kind of sets up a table and starts, calling out people and handing them a card. They do not know anything about what is really written in the card, or what the card is going to do for them, and what exactly am I supposed to do with that. But whenever they ask a question, if at all they are answered, they are told, this is going to help you in your hospitalizations. And the second part is this thing that when they do go to the hospitalizations, they are kind of, faced with a certain loss, certain differentiated, service level. Oftentimes, they are basically prioritized the last. And that basically kind of, creates a huge amount of quote unquote tax on their ability to use those state-led insurances. So what the essence I'm trying to drive to is this, that while a bureaucrat is going to assess an insurance purely from his perspective, and I'm a finance professional, I'm going to say, insurance, great. So yeah, like, it's not that, so I'll be going into the nerdy mode. Hey, this is the risk of ruin is a risk. What do you do with risk? You either absorb it, you either share it, you either pass it on, and these are the three things you can do. So the point is this thing that, okay, if you cannot absorb it, great, because it's creating a risk of ruin. Where you cannot share it, no one is going to share it with you. So you pass it on. So insurance is a thing. And that's it. I'll be saying, all right, the job is done. But that is me as a high-level finance guy who is talking. If I do that to my, even a non-financial person, he or she will be completely in the waters, deep waters, because trying to understand that what exactly am I going to do? And especially when someone else is buying that insurance for you. So the problem in essence is this thing that both the individual is not in charge of the transaction or not in charge of the decision making. When that decision making is done for that person, there is no effort at educating that person. When that person, even if that person comes to know about the features of the card, and when that person is going to the hospitals to avail that services, there is a differentiated level of services. And even when the service is actually delivered, there is a huge amount of paperwork to fill just before that. Understand this point that our paperwork is always written in English or some very highly formalized dialect of the local language, or for that matter, Hindi or something like that. That person who is a vulnerable member of the society is going to look towards the good Samaritans around him to actually help him fill up the form. So it's a complete failure on our part to imagine the usage of the insurance interventions from the ground up. So what I led with that, hey, let's add that add-on. Hey, hospitalization is taken care of, OPD is not taken care of. Let's expand the insurance to add that add-on. So that is a very flawed way of thinking, and we have to kind of expand it to include the people factor. So what is the way out? I propose that we basically build a team of contractual telecallers, with each telecaller being assigned X number of households, and these telecallers' job is to do monthly or weekly or bi-monthly connects, who will basically quote unquote the relationship managers of them. And I mean relationship managers in the deepest sense, not in terms of the relationship managers that we are used to seeing in the current day context, where relationship managers act as salesmen. I'm talking about people like, who are basically going to educate them and understand them. And remember this point that it is not going to be a 15 seconds kind of conversation. Yes, you can go to that, and etc. etc. There'll be a lot of questions, and the person has to answer that. And there'll be a lot of counter questions as well, because it's a complex concept. The fact that someone is going to pay for me and pay for my pain in exchange of something else, which I do not have to bear because state is bearing for it. It's a complex concept. So there will be required multiple touch points. But I propose also one thing, that we basically digitize and rationalize all our forms. Let the team of telecallers do the entire static data collection beforehand, and link it with the insurance card number or whatever it is, or household card number, whatever it is, so that the person, when they go to the hospital, they show just that card, and they do not really have to kind of bother with asking for help from the good Samaritans to help that. So it's a kind of completely ground up reimagining of it. So, for example, one of the insurance schemes had 24 line items on their form. Now, imagine, first of all, a language barrier, but also, even if I'm asked to basically fill a 24-line form, I'm going to cringe and crib and say that can it not be postponed till my ward goes to till my ward is actually started treatment. And that basically, if my child is basically, suffering from like needs an immediate medical attention, I'm going to tell to the people, tell to the hospital people that, my ward is basically, my kid is basically in need of an immediate attention. Let us not basically go into that. So that is basically my point, that let us create a team of telecallers, and I call it Bima Dost, but you can call it whatever it is. This is what Bima Dost is supposed to do. And the good thing about having a team of telecallers is also this, that when we want to expand the bouquet of interventions, we can fall back upon these teams to explain to them, explain to the beneficiaries that what we are looking for, what we are trying to achieve, what we're trying to do. So, for example, you basically kind of think that, you are going to kind of create, add that add-on, OPD add-on. Cool, let's do that. But let's say that you do not want to basically also have a state-led insurance model, because remember the dignity problem, the dignity problem is still intact. We cannot really solve and wish away the dignity problem. So there has to be a way so that the most vulnerable members of the society can actually call the shots in what they actually want in their own insurance products. So, for example, if I am basically a bunch of very young folks, I do not have very senior people in my family, I may wish for a different set of clauses in my insurance product. But a bureaucrat sitting in the state capital or the national capital will not be able to really tell the story and think about my story. And thus, I lose the control over what my desires and wishes are. So there has to be a kind of a market-led solution over here. There's no doubt about it. But then how do you really do it? Because remember one thing, that India lives in many continents. So how will you ensure that someone who is basically having just 10 rupees of spendable income per day is able to kind of afford an insurance? What we propose, what this paper proposes, what I propose is this, that this basically implies the same old problem that we tried to solve a few years back. Think about pensions. What is the problem of pensions? The problem of pensions is this, that I do not have enough money to fund my own retirement. Full stop. Rephrasing that same problem in a different way, in specifically pharmaceutical context, I do not have enough money to fund my insurance transactions, or for that matter, the insurance allied expenditures. So remember, when I go for an insurance, I still have to pay for both the insurance premium itself and also the other amount, that basically a small nominal amount that I have to still spend out of pocket. So this is basically kind of, this is kind of called co-payment and all those things. So the idea that I'm trying to bring to is this thing, that even with a full insurance, you do not really go down to 0% out of pocket expenditure. You do still have some amount of a token amount, so that no one is doing moral hazard and those kind of things. But still, the essence is this thing, that just like a pension problem, this is an affordability problem as well. Like I'm not able to fund my retirement, I'm not able to fund my medical expenses. So just like we solved the problem, or tried to solve the problem, and then we undid it, but that's a different matter, that we solved the problem for pensions using a NPS-like setup, where we said that the long-term liabilities the distant liability 30 years away will be funded by regular payment and subsequent investment in market equity linked products. Similarly, what I'm suggesting is that let us create something called healthcare savings and investment accounts, HSIA. In short, the government will basically kind of seed those accounts, and those accounts will be managed just like an NPS, and those will be invested in the equity markets. India, remember the problem with Indian manufacturing and Indian innovation problem, and that it works. And of course, if time allows me, I'm going to touch briefly upon that. The entire dysfunctionality of the ecosystem is this, that even though government is trying to create a lot of affordability, it's trying to address the affordability problem, we still face the highest medical inflation in Asia, 14% rates. But worry not, because it turns out that 14% is good enough. 14% inflation is adequate enough for equity markets to tackle. In the last 10 years, since the time that NPS has gone public, we have experienced 14% rate of growth, CAGR, over the last 10 years. This is good.
Yeah. NPS fund.
Pardon?
We're talking about the return, the CAGR of NPS fund.
That's right, NPS fund. So imagine the same story repeating in HSIA as well. So what really happens is the thing that the money that I invest today through HSIA is also going to grow at 14% level, which is basically, at least we can expect that it's going to grow at 14% level, because we do have a case study showing that evidence. Yeah, we can further kind of argue that, hey, look, Soham, we have been kind of growing at an extraordinary pace in the last 10 years. We will not continue that story again. We can quibble over those ideas, and those are important ideas. Those are important things. And we can talk about that, what should be the other aspects to ensure that HSIA accounts do fulfill the mandate that we are setting it out for. But the idea is this thing that equity returns are able to fund your inflation, especially your medical inflation. So what my point is this thing: let the government not buy the insurance for the vulnerable members of the society, but rather empower the vulnerable members of the society to buy it for themselves. Again, remember this point: HSIA itself is a complex product. Try as we might, it is a complex product, and it requires a lot of education and hand-holding to kind of understand that basically, what exactly is the implication of this. And that's why we are again going to fall back upon Bima Dost to kind of explain these kind of ideas as well. So the overall essence is this thing that Bima Dost can actually be a kind of what in military jargon is called force multiplier. Let the sophistication part be taken care by the thinkers of the world, and its adoption and the barriers to adoption are being solved by the Bima Dost people. So what really happens is this thing that we are able to kind of bring the best of the both worlds, where we are able to bring financial innovation and its adoption, ensuring that their sophistication level is bridged by hand-holding with the dedicated telecallers. So that is basically one of the core problems that are kind of are weaved together. This is the insurance conundrum. If we have insurance, why are we not able to solve it? And we are not able to solve it because we are not hand-holding the ultimate beneficiaries about what the really insurance goes about. The second aspect, and I kind of briefly mentioned earlier, but now I'm going to really touch upon it, that let us unpack further then where the unaffordability problem comes from. I, as a poor man, go to a doctor. The doctor writes a prescription. I take that prescription and say, like, it is paid for. All right. So I'm going to a state-led hospital, state-sponsored hospital. It's free of cost. I take that prescription and go to the pharmaceutical company, the local, the in-premise pharmacy. I go to that pharmacy and give him my prescription. And the person says that, you know what, you have got 4 medicines prescribed. I can only fulfill 1. The rest 3 are not there in stock. Remember, pharmaceuticals are time critical and we cannot substitute them and we cannot basically go for a reduced dosage or something like that. So I'm going to take that prescription and go to the private pharmacy players and ask them that, please help me, fulfill this. So what just happened is the prescription bounce. My inability to fulfill the prescription. You can measure the bounces in either the number of line items that I was not able to fulfill or in the value that I was not able to fulfill. Value numbers are a bit hard to get in India, but the idea is so basically the entire data around prescription bounces is like we can make do with a lot more granularity. Like, is it basically high value medicines that are getting bounced out, or is it the across the board generic medicines also that are getting bounced out? So we do not know exactly a lot of the contours of this problem. But the idea is this thing we do know though that the private pharmacies face a prescription bounce of roughly about 12%. Whereas, hold your breath, the government-led pharmacies face a prescription bounce as high as about 60 to 65%. But what exactly is the reason of these prescription bounces? What exactly is the problem? There was a situation where long way back when there was a public distribution of food grains, the PDS system, where there was a leakage of medicines leakage of food grains from basically the subsidized ration shops to the markets. That is fortunately not the case today. If we want to kind of draw the linkage between the ration shops and which are subsidizing the food grains and these pharmacies which are subsidizing the medicines, that is thankfully the world has changed. It is not the case today. So there's no leakage per se. So there's no corruption per se. So that makes the problem suddenly more difficult to solve. If there is no corruption, if there is no evil malaise, the problem becomes it is ineptitude. And the ineptitude is not necessarily from the pharmaceutical, people who are manning that pharmacy shop. Because, hey, it is out of stock. It is not that the quality of drugs is out of respect, is bad or something like that. So it's a supply chain problem, really. So now you just basically go up the supply chain and try to find out who basically is supplying the drugs. And lo and behold, we do find a massive amount of problem in how the state manages the procurement of medicines, storage of the medicines in its own warehouses, and then eventual distribution of the medicines to its, last mile pharmacies who are ultimately going to serve the consumers. Again, we do not have a lot of data, but we do understand that how the how the states who manage their drug procurement are able to conduct their affairs vis-a-vis those who are not able to. So, for example, and there are multiple models of these drug procurement operations in India, but the broadly one is, which is basically state-led. Bureaucrats, with no special knowledge necessarily, where governments with a lot of discretionary power to intervene in those technocratic decision-making, are setting up committees, and those committees are kind of, doing the decision-making on themselves, by themselves. So these kind of setups often see a very little inventory management quality, very little demand forecasting, prowess, and very little ability to control for the overall quality of the storage and all those things. Remember, drug storage is a complex business itself. It also has a temperature. It also requires a cold chain solution as well. And with cold chain in an energy costly country like India, you do have costs as well. So it's a multi-variable optimization problem where basically, how do you and that requires technocratic knowledge. So we do often see that these, the states where there's a lot of intervention from the government really perform poorly. However, contrast this with states like Kerala, Maharashtra, where there is a lot of autonomy. In fact, the drug procurement agencies are autonomous. These are known and these have been found to have very sophisticated, at least sophisticated from the sense of government, from an Indian state capacity, that sophisticated level of technocratic knowledge and procurement, capability. For example, these autonomous organizations actually spend a lot more per person than a state-led model. Yeah. So if my memory serves it right, Kerala spends about 51 rupees per person, whereas the state-led model of UP, West Bengal, and others spend about 7 to 8 rupees per person. Yeah, that's one thing. The second thing is, how do they store it? Yeah, often researchers have found that in the state-led model, the medicines are taken delivery of, like the medicines that are being taken delivery of, are not checked for the expiry dates. They are stored very inappropriately. Yeah, so those kind of problems are there. Often in these departments as well, the autonomous drug organizations kind of do better. Demand forecasting. There are states like Orissa who do not really have a dedicated demand forecasting process at all, but rather the clerk actually kind of just adds a 25% or 20% kind of a multiplier on top of the last year's demand and brings up the total amount and basically sets floats a tender for that. So the idea is that state-led drug procurement agencies do worse in almost every factor that matters. The question is then, is it a surprise that Kerala has a lower number than something like an Orissa or Punjab for that matter, Punjab, Haryana for that matter? So the idea is, if we fix this aspect of the business, we are able to kind of make a very serious dent on the drug affordability and the availability in India. So how do we really go about fixing it? Remember this point, this is in the states ambit. And when I say state, it is state with a small s. So that means the individual states in India's ambit. How, as a national government or central government, can actually do this thing? Yeah. So the point is, we can offer incentives for them to kind of transition, but I do not think that the incentives will work that well. Public choice theory wants says that every bureaucrat is going to fight tooth and nail to protect their turf. So a lot of incentive has to be spent to basically nudge those bureaucrats away from those controls, command and control kind of situation. So what is the way out? So what I propose is that let us, and this has certain level of isomorphic mimicry built into it. I have tried to reach out to certain people to kind of critique this idea, but I have not really found any yet. What I'm saying is, let's basically leverage group purchasing organizations. Let us think about leveraging group purchasing organizations to do the procurement on our behalf. Disband this entire thing and let's go for the GPO system. Of course, we will basically make it optional. We'll not keep it a mandatory clause. So there will be states who will basically say that, I still do not care for giving up the control. Yeah, but there will be states who will be saying, all right, let us go forward with it. And the group purchasing, what is the economics of group purchasing organizations? The idea is we basically kind of, we agglomerate all the demand from multiple institutions together, and negotiate with the manufacturers separately and get the data, get the stuff to the people who to the medical institutions that want it at the cheapest possible cost. So basically, it's a game of volumes. Yeah. And what is the economics of it? The GPOs charge about 2 to 3% of the gross value as fees. So it is in the interest of the GPOs to basically drive down the price, because if they are not competitive enough, then the medical institutions will basically switch to another GPO who offers more competitive this time, and it becomes a winner takes all kind of a situation. Yeah, so we can basically have GPOs in India, and the national government can say, hey, we have Ayushman Bharat, kind of all those Jan Arogya Yojana and all those things, Jan Arogya Kendras, and all those kind of medicine procurement that we are already doing. We are going to basically have those GPOs start not with a zero number volume, but rather all my procurement will be through the GPOs themselves. So I'm basically kind of, setting up a seed volume on day one for the GPOs to kind of optimize on and negotiate with the, with the manufacturers on. And now a state like UP can say, hey, look, if otherwise I do it myself, I'm getting this kind of a prices. But because I'm kind of piggybacking on a mothership of national government doing procurement, I'm getting a far more competitive price. And there is an overwhelming incentive now, a built-in incentive now of budget saving by moving to a GPO-based system. Now, remember, GPO is completely private-led guy, and he will be having the technocratic knowledge to kind of, and also the incentive to ensure that, he's not really buying a drug that is supposed to get expired in the next 1 week. He's expected to save and store the drugs in a proper way so that, what requires cold chain and what doesn't require cold chain, he's doing all that. So there's a certain amount of efficiency in that. But on top of that, the GPOs can also be incentivized to act as consultants to these individual states to offer them forecasting services, demand forecasting services, that is. And that, I think, solves almost all the problems. GPOs can be then, told that, hey, look, I'm not even going to do the logistics parts as well. Take 0.5% of revenues more, but do the logistics part yourself. That is, your job is to kind of ensure that the prescription bounces come down from 60 to 70% to 12% to match the private levels. For that, I'm going to basically pay. So if we were paying 2% of our gross supplies to you as fees, for demand services, demand forecasting services or consulting services, I'm going to pay 0.25% extra. And for the logistics amount, I'm going to pay 0.75% extra. And lo and behold, for 3% of the amount of 4% of the gross amount, I'm able to solve the entire problem. So the idea that I'm trying to get to is this thing that there is merit in opening up the procurement process to market competition and market forces to ensure that we solve this problem. But speaking of the market forces and market prowess, there is another very insidious way that affordability problem rears its heads. It is not that the government is not doing enough to basically solve this affordability problem, but government is kind of going about it in a first level order of thinking way. There has to be a second level order of thinking, third level order of thinking baked into it for any intervention to work properly. I'll give you an example. Jan Arogya Kendras, JAKs, are basically private entrepreneur-led public distribution of medicine system, if I can call it that. Often the medicines that are received from these kind of these kind of shops are priced as low as 10% of the lowest price available for a drug in the market. So if I go to a normal medicine shop, if a paracetamol costs me 1.2 rupees per tablet, and I'm making the stuff up randomly, then the Jan Arogya Kendras will be pricing it at 12 paise. Yeah. So the idea, what is really happening then? The idea is with such low levels of pricing, the profit margin is often razor thin. And to ensure that the profit margins make sense, I have to ensure that I'm supplying to a large catchment area. That means I'm going to go for places where there are already a lot of people. That means I'm going to go for cities. So just imagine this thing. Delhi has as many JAKs as Bihar in total. Yeah, Mumbai has more JAKs than the most poorest district in Maharashtra, Gadchiroli. So this kind of also plays insidiously in the factor that even if we wish to, we cannot access the JAKs because there is none over here, because the economics is not working out for the entrepreneurs. And remember, the poorest and the most vulnerable of members of our society are in the very areas where JAKs are not there. I missed the exact numbers, but as late as 2017 or 18, I guess, there were about 300 to 400 districts which didn't have any JAKs. Roughly another 500 districts or something like that, which had only 2 JAKs, less than 2 JAKs. And usually in India, we basically have about roughly 10 lakh people to 12 lakh people, per district, I think. So to have, and perhaps, my numbers are off over here because I just have lost count of how many districts that we had. But the point is this thing that when I was writing the paper, then it was kind of coming out to be a laughably off, the numbers were laughably off in terms of accessibility. Yeah. So the idea that I'm trying to get to is that if you have to kind of ensure that there is a democratization of the access problem of medicines, then you have to ensure that the JAK is spread out. And for JAKs to spread out, remember, this is a private, you have to kind of set the incentives so that the private entrepreneurs open more JAKs in the areas where there is less competition or where there is less number of people, or for that matter, where there are more poor people. So you have to fix the economics of the JAK folks. There are some evidences that JAK entrepreneurs really do not make any money after basically, you slash the expenses and all those things. You adjust for the expenses and all those things. The running expenses, the expenses that you have to have for an assistant, you have the expenses that you have to bear for the computer terminal that you have to have because all the sales have to be digitized and all those things. If you there is a still tiny profit that they make, but that is not economically viable. But the beauty of this entire problem is this thing that the JAK medicines are not uniformly priced dirt low, dirt cheap below the lowest market price. there's some evidence as well that we can basically benefit from some rationalization. That means there are some medicines which are actually priced slightly above their lowest market price. Yeah. So, for example, if you do have something like, say, for example, a liraglutide. Yeah, liraglutide is a diabetes medicine. The lowest market price is somewhere about 4,000 rupees for that, and basically you do have the JAK supplied liraglutide being priced at somewhere about 5,500 rupees. So we can basically create some savings over there as well for the individuals by slashing the price over there. But for the majority of the other medicines, there will be a lot of benefit to be had if we rationalize the prices to be within the 30% of the lowest market price and not 90% off from the lowest market price. So the idea is, let us basically rationalize the drug prices so that it is within the 30% band away from the lowest market price. That way, we are going to expand the margins and the profitability of the individual JAK entrepreneurs. We are going to ensure that the people are still able to afford the drugs. They will not be saving as much as they were before. But hey, would you rather have no drugs and theoretically save money on paper? Or would you rather have a JK in your neighborhood and save less money than the ideal case? I would always go for the later one. It is better to opt for good enough than settling for chasing perfect. So, and this requires no state capacity per se. All the other things required us to spend money, all the other things required us to invest in state capacity and other aspects of it. This is a stroke of the pen thing. We are just ensuring that the prices are rationalized. That's it. And when the prices are rationalized, we demands no extra investment from our side. We can keep procuring at the same prices and the same processes that we were already procuring for. We are not spending any extra money. We are not building any new state capacity. And just by ensuring a slight improvement in the prices, the private investors are incentivized to make the drug affordability problem much more, to address the drug access problem. So this is basically the idea that, I think is readily doable. Yeah. So what basically it comes down is this, that we need a second order, third order level of thinking to kind of address these kind of problems. But I would always say, let us disband with the NPPA, National Pharmaceutical Pricing Authority. This is not doing any help to anyone. We are trying to kind of reduce and crimp the prices, and yet we still have 14% medical inflation. To what use is NPPA? Let us disband the DGCO, Drugs General Control Order of 2013, that actually set up the drug pricing, that list where basically there were certain drugs that were classified as essential medicines, and the price cap was fixed. It's directly hampering on our quality problem. There are other if we want to be basically very hell-bent on immediate effects, then we can basically ask for interventions which which has a lower lag effect. For example, solving the Jan Aushadhi Kendra economics, getting the GPO problem installed, the GPOs installed in our system, in our medical procurement system. These will have immediate effects as early as 1.5 years. So the idea is that to solve the drug affordability problem, you have to go the non-intuitive way. You cannot be doing price controls. You have to fix the incentives. And that's all that basically, we can do to reliably address this problem. So just to summarize, I'm proposing, let's add that add-on, that OPD add-on. Let's get the HSIA up and running. Let's get a Bima Dost kind of a contractual telecaller team set up. Let's fix the economics of the Jan Aushadhi Kendra. Let's get our GPOs to tackle the complex problems of procurement in our state, in our state-led pharmacies. And finally, for heaven's sake, let us do away with this NPPA thing and let us do away with the foolery of the DGCO 2013 order. So yeah, that's that.
Great. So yeah, so that was the affordability piece of puzzle. And it was a great revelation for me also. There are a lot of new ideas and things which, so the basic idea which I think where I started, understanding the whole thing was presence of the negative externality, wherein you clearly explain how somebody who's not able to afford a life critical drug, and then that drives him to bankruptcy, and that kind of increases the cost of credit for in that community. There's a clear case of externality, and that's why we need state intervention. That makes the case for state intervention. And of course, after that, you laid out the whole plan. That sounds very interesting. I'm really excited to talk about the remaining two other pieces of the puzzle: the cost and the quality and the innovation part. Looking forward to the next episode, and we will discuss the remaining two pieces. Maybe we'll do one more episode. So one for the quality and one. Great. Thanks a lot for your time, Soham.